Hello, friends. So I'll be giving a overview on this interesting topic that I was asked to give in Gorakhpur as a part of the workshop. So it's about the current management of cardiogenic shock. So although it's about cardiogenic shock, we need to understand that cardiogenic shock exists concurrent to acute decompensated heart failure, and they both have a complex interplay and they don't present as an isolated, so they have an interplay of both conditions. So we need to touch about the salient aspects of acute decompensated heart failure and cardiogenic shock together. So when we talk about heart failure, as I said, so now the new classification is they have categorized it into three broad categories. So one is heart failure with preserved ejection fraction, and the second one is heart failure with moderately reduced ejection fraction, where your ejection fraction is 41 to 50%. And then you have heart failure with reduced ejection fraction, where your ejection fraction is less than 40%. So this is the classification. And increasingly, friends, as you would recognize that we are seeing heart failure with preserved ejection fraction is as coming in most commonly into ICU. And acute decompensated heart failure, when it exists, it also exists in different flavors or different sort of a characteristic. So one is with no pulmonary edema. The common ones that we tend to see is with pulmonary edema. And the third one is with high output heart failure. And the fourth aspect is in the setting of right heart failure. And of course, as I said, that acute decompensated heart failure and cardiogenic shock, they exist in conjunction. So the fifth element that it presents as is the cardiogenic shock. And it is shown that 16% of them tend to have pulmonary edema, out of which less than 3% have severe pulmonary edema. And this severe pulmonary edema tends to happen not in the presence of shock, but with the accelerated hypertension with systolic blood pressure more than 180. And this is something we see quite commonly, that patients come acutely short of breath from the ward. They get shifted to ICU, and you would see the blood pressure sitting on a very high normal at around 180 or 200, and they would be in pulmonary edema, severely distressed. We give NIV, NTG, so on and so forth. And that's the typical presentation we tend to see in our hospitals. And they have categorized into this checkerboard sort of a situation of acute decompensated as warm, dry, warm, wet, and cold, dry, and cold, wet. What we commonly see is the warm, wet, or cold, wet. So the warm and wet is tends to occur most commonly in older adults, females. More than 70% of them tends to occur in the older adults. And this is typically more like heart failure with preserved ejection fraction. They come with pulmonary edema, and their propensity to have pedal edema is lesser in warm wet. So the cold wet is what we tend to see with cardiogenic shock, occurs in less than 20%. And these are the patients which constitute around 20% of acute decompensated heart failure with low cardiac output and cardiogenic shock sort of a situation. And these are the patients who are at an increased risk of death, friends, as compared to the warm bed. So warm bed, because they have possibly preserved ejection fraction or moderately reduced ejection fraction, they tend to have a better outcome. So the multi-organ dysfunction state typically tends to occur in this 20% category where they have a low cardiac output and shock situation. And these are the patients who go on to needing heart transplant in 1 year is what has been referenced. And warm dry is less than 10%. So when you look at this SKY classification, which is a Society of Cardiovascular Angiographic Intervention group, so they have categorized cardiogenic shock into A, B, C, D, E category. It's a pyramid approach. A is trying to identify patients who are at a risk for cardiogenic shock with no signs and symptoms, and who tend to be hemodynamically stable. So this I would say possibly come into this 80% with preserved ejection fraction who are hemodynamically stable with no signs and symptoms of heart failure. So, but we have to identify these patients who are at a risk. So B is that patient group where there is a beginning of hemodynamic instability that tends to set in, where hypotension may be setting in, and these patients may have tachycardia. But the B category do not have features of any hypoperfusion or perfusion issues is something that is not there in B. So once they get into the C category of cardiogenic shock, this is the classic type of cardiogenic shock where blood pressure is low, needing vasopressors, and there may be features of hypoperfusion with low blood pressure. And C is the situation we tend to see in ICU where they start needing vasopressors, inotropes, and maybe mechanical support like balloon pump, ECMO, so on and so forth. The D is more catastrophic situation or deteriorating condition where patients, despite whatever your support, they've come in a late stage where the rapidly deterioration and there is a cascading need of supports with regards to vasopressors, mechanical support, and organ perfusion is gotten worse with multiple organs getting affected and they're in a proper shock situation. E is, as the name suggests, is very imminent and extremes of disastrous sort of a situation where the risk of mortality will be very, very high. So why this pyramid classification of cardiogenic shock? Because the epidemiological data has shown that the mortality also sequentially increases when you are progressing from A to E, which is very nicely depicted here. Because when they are at risk, as you see, the mortality is only 0.6 to 24.9%. But when they are in the beginning stage, as you see, so the mortality tends to increase. And once they are in C, D, and E, so you would see once they go to E, the mortality sits at 95.5%. At D, it sits around 62.9%. And at C, it sits at around 49.6%. So this is the reason why we have this stratification happening. And when you look into the phenotypic classification, so basically you have phenotype 1, phenotype 2, and phenotype 3. So as the name suggests, phenotype 1 is predominantly cardiac involvement, where RV and LV are involved. And phenotype 2 is where you have a renal involvement, and phenotype 3 is where you have a liver involvement. So this is phenotypic classification. And when we call someone as a cardiogenic shock, they obviously tend to have certain clinical, myriad of clinical features which categorizes them as cardiogenic shock, where because of low cardiac output, they could have confusion and lactates are more than 2 millimoles per liter. Systolic blood pressure typically will be less than 90 millimeter. And because of low cardiac output, once they go into phenotypic classification of 2, there will be acute kidney injury that sets in because of hypoperfusion to the kidneys, and the urine output would be less than 30 mLs per hour. They would have cold periphery. So these are the situations. Once they're in a situation where they have signs of low cardiac output, manifesting with these features, one, it becomes mandatory that arterial line has to be put in place so that they have invasive monitoring of blood pressure happening for optimizing these patients better. So this is, I just like to emphasize here, many times we see patients sitting with cardiogenic shock and some of the specialists say we do not want to have an art line. I think this is absurd and I would say it tantamounts to malpractice that any patient with hypotension needing vasopressors and where there is a second to second monitoring of blood pressure that is needed, friends, arterial line is mandatory. I've seen in CCU many of the cardiologists. I have no hesitation in telling the cardiologists very often would not prefer to have arterial line. God only knows why. And this is a malpractice. You look into the evidence, all the literature says they need to have invasive line to monitor the blood pressure closely. I have no reason to believe why some of the cardiologists have this strange behavior. They wouldn't want to have an arterial line. And when you look into the clinical features of cardiogenic shock, obviously it's imperative and very important that you have a good clinical acumen. They would have high JVP, and this is the easiest sort of a sign to pick up in these patients. So I always tell my trainees during rounds, please look into JVP because very often we can pick up this cue and you don't need an ultrasound to say they have B lines and you need to give diuretics. Simple JVP being high, which is a very easy clinical sign to pick up, has a specificity of 93% and sensitivity of 57% to recognize that this patient. Of course, I use this as an adjunct to all the other different modalities that we would use. And they many a times would have pleural effusion and they would have crackles and wheeze. And on examination, they'll have a gallop and few murmurs if there is a valvular lesion. And when there is predominantly right heart failure, there would be hepatomegaly and they could have ascites and pedal. Now, this is a pictorially very nice depiction of typical features of heart failure with cardiogenic shock. that they can have any of these features, one or two or more of these sort of a features. So when we talk about cardiogenic shock and heart failure in conjunction, we need to obviously point out and look into what are the etiology and precipitating factors. So the commonest etiology, friends, as we all understand, is acute coronary syndrome or someone who's had a myocardial infarction or complications of acute MI or ACS leading to ventricular septal rupture. So the commonest is acute coronary syndrome. The second commonest is simple arrhythmias. So someone who has atrial fibrillation with fast ventricular rate, we know very often they are pushed into heart failure with hemodynamic instability, which you could call it as a cardiogenic shock, atrial flutter, or it can be more sinister sort of arrhythmias like ventricular tachycardia, ventricular fibrillation, or heart failure, ventricular ectopy. So all this can push someone into decompensation and cardiogenic shock. And there could be infective conditions like myocarditis or autoimmune conditions, which leads to myocardial dysfunction and cardiogenic shock. And there are valvular lesions like severe mitral regurgitation or there's tear of the mitral tear or perforation or aortic regurgitation or progression of ventricular septal defect. All these are also something that pushes someone into heart failure and cardiogenic shock. And there could be various types of cardiomyopathy, like there can be hypertrophic cardiomyopathy, restrictive cardiomyopathy, or dilated cardiomyopathy. And very often in ICU, we tend to see stress-induced cardiomyopathy, where there is apical ballooning of the LV, which we call it as Takotsubo cardiomyopathy. All this can lead to shock situation, and they do categorize as heart failure with cardiogenic shock or uncontrolled hypertension, which leads to heart failure and then decompensation with hypotension later on. All these are sort of etiological factors for cardiogenic shock. So when we talk about diagnostic evaluation, friends, so obviously history becomes terribly important, and a good clinical acumen with clinical examination and evaluation of risk factors and comorbidities are also important tenets to bear in mind when you are evaluating a patient with cardiogenic shock. And of course, the integral investigations that are needed is ECG and radial and imaging of some sort, X-ray, echocardiogram. Echocardiogram becomes integral in establishing the diagnosis of heart failure and cardiogenic shock. And NT-proBNP is a easy sort of a biomarker which gives you some direction and helps you to navigate the etiological sort of a rationale for a patient who comes with shortness of breath. So these are the intuitive sort of investigations that you would do. And ECGs are needed to ascertain whether there is an underlying arrhythmias, whether there is an ongoing acute coronary syndrome, or whether there is some tachyarrhythmias that are happening to ascertain and delineate the causes of cardiogenic shock. So when we talk about monitoring in cardiogenic shock, so the monitoring tools that you would pick up is to assess the severity and the etiology. So the clinical tools remain sacrosanct, and 12 lead ECG with a sort of a standard ICU monitors, which monitors the ECG, heart rate, the blood pressure, or saturation, so on and so forth, are quite expected to be the standard sort of a monitoring. And echocardiogram, as I said, is integral to monitoring these patients with cardiogenic shock. And many a times, see, echocardiogram, you would do it intermittently, but we possibly may need some sort of a continuous sort of a cardiac indices monitoring. So transpulmonary thermodilution techniques to assess the cardiac output, to look into the pulmonary vascular resistance, to look into the stroke volume resistance index, so on and so forth. All these may be needed in a complex cardiogenic shock where we need continuous monitoring. So when you look into the sort of lactate, we know that lactate is a marker of outcome in sepsis. So even in cardiogenic shock, these are the studies which have shown if these patients have increased lactate, they have a direct correlation to worsening of mortality. And like in sepsis, if there is a good lactate clearance in cardiogenic shock within 8 hours, it is a good predictor. It's an independent predictor of hospital survival and mortality. So if there is no clearance within 8 hours, it's a predictor of mortality. If there is a good clearance and there is a possibility of good survival, so it's very similar to sepsis. Even in sepsis, lactate clearance is shown to have good correlation to survival. So is the case in cardiogenic shock. And monitoring, so very important, friends, it is shown that transthoracic echo is good enough Transesophageal echo has not shown to add any additional value with regards to monitoring these patients with cardiogenic shock. When we do transthoracic echo, it is really important to assess the LV and RV and try to delineate whether predominantly it's a LV driven heart failure and shock, or the RV driven heart failure or shock, or is it a biventricular shock. So that is why transthoracic echo is important. And of course, it's a structural and functional assessment of the heart. So echo helps you to estimate the cardiac output, estimate cardiac index, estimate the systolic function, diastolic function, and estimate various pressures like right atrial pressure, LV filling pressure, and pulmonary artery systolic pressure. So echo pretty much does everything what your continuous sort of a cardiac output monitor with transpulmonary thermodilution would do, but it also gives you a structural insight into what may be the existing underlying problem. And of course, transpulmonary thermodilution techniques like pulmonary artery catheter or pico catheters or Vigilio, so on and so forth, could be put in place for a continuous monitoring, or stroke volume variation or pico to assess the global end diastolic. So all these tools could be considered based on the availability if one is looking at a continuous monitoring of these patients. But echo gives you a good snapshot of all these functions along with the structural element in cardiogenic shock. So this is something we need to know. And friends, for intensivists, we know pulmonary artery catheter may not have a role, but in cardiogenic shock and in cardiac patients, there are good signals that pulmonary artery catheters has benefit in navigating you through this clinical conundrum and maybe optimize outcomes. So obviously, when we use ultrasound, we also look into the lung parameters. So we look at whether there are A lines or whether there is a rock comets, B lines, what we say. So if there are B lines which are separated by 7 millimeter, there is interstitial edema. But when they're very coalescent and much closer in less than 3 millimeter, then the severity of edema is a lot more. It suggests more of alveolar edema. So along with echo assessment of the heart, we also look into the lung ultrasound to look at the pulmonary edema severity, which can be quantified with your ultrasound. And B lines tends to extend to the bottom. And why B lines happens due to the reverberation of the sonological waves between the interlobar septa is what determines the occurrence of B lines from the physiological standpoint. So these are just some of the echocardiograms which show. So this is an interstitial edema, friends, where B lines are separated by 7 millimeter. And if you look at the one on the right, so this is alveolar edema where it is a lot more coalescent, and where the B lines, the distance is less than 3 millimeters. So we call it as lung rockets, B lines, or comet tail artifacts. So when we talk about B lines, 1 to 2 B lines is considered normal in 28%, more than 3 is pathological. So there are other differential diagnoses of B lines. Obviously, heart failure is one. So there may be non-cardiogenic sort of a causes for pulmonary edema like ARDS, ILD, or pneumonia also. So when there is no A and B lines, consolidation or pleural effusion has to be looked into. So we follow something called blue protocol. So where we look at the lung sliding, and if lung sliding is present, whether we look for B profile, where there are a lot of B lines, as I have shown. If that is there, you call it as pulmonary edema and you attribute it to the cardiac. If there is a profile, one has to look at the ultrasound and to look for any venous thromboembolism. If ultrasound is normal, then you have to do PLAPS to look for any pneumonia. No PLAPS, you have to think of COPD. So this is an algorithmic approach to any shortness of breath that comes to your ICU. And when there is a B predominant profile, which can be present with the underlying consolidation. If it's a predominant profile, then one has to look into any localized pneumothorax, or alternate diagnosis has to be looked at. So what I'm only trying to say is echo and ultrasound are integral and valuable to ascertain various components of cardiogenic shock and heart failure. Of course, we do Doppler measurement like E by A, deceleration time, and we look into E by E prime to look at the filling pressure by these maneuvers. I'm sure most of you who are listening to this would be doing it. So E by A is a very simplistic way of ascertaining your diastolic function of the heart, where we measure the E and A. So the normal deceleration is 160 by 240, and E by E prime is a static measure to assess the left atrial pressure. So using tissue Doppler. So it's a very simple tool. So with which you know that you can ascertain whether your left atrial pressure. So it is akin to pulmonary capillary wedge pressure. So when you look at grading, grade 1 is E by A less than 1 and E by E prime should be less than 8, which is the left atrial pressure is less than 8. So if grade 1A, your left atrial pressure is much higher. So it's typical to pulmonary capillary wedge pressure being high. Grade 2 is E by A is 1 to 2 and E by E prime is more than 15. Grade 3 is E by A more than 2 and E by E prime is more than. So as you see, after grade 1A, they have increased LA pressure, which means they are in pulmonary edema and you need some sort of a preload, sort of an optimization. So it's a very simple tool which gives you a snapshot indication of whether there is a high sort of a capillary wedge pressure being high. So when we talk about monitoring, so we spoke about in detail about ultrasound and echo as to the different components that we look into to ascertain the fluid component and to help us calibrate your therapeutic modalities. There are other tools that you can use like mixed venous oxygen saturation, which looks into the sort of a balance between oxygen delivery and oxygen consumption in the tissues. Or the simplest thing is to look at the PCO2 gap. So, which is the gap between arterial carbon dioxide and the venous carbon dioxide. If it is more than 6 millimeter mercury, it is an indication of low cardiac output. So this is a simple tool that you can adopt on the bedside to assess the optimization of the cardiac output, which could be measured every 4th hourly. And this has been validated from the study that came from the Canadian group. And as I mentioned, friends, pulmonary artery catheter, although most intensive, is considered as an obsolete. But when you look into the cardiology literature, so these are two studies which have shown that pulmonary artery catheter has still got a very good role in prognosticating the patients with cardiogenic shock. I think that is something that we need to bear in mind. So when we talk about management, as I said, you would obviously connect the patients to the monitor. You would administer oxygen to these patients and there would be an IV line. And NIV has found to be significantly helpful to the patients in heart failure and cardiogenic shock with preload optimization. With if there are high preloads, obviously you have to give diuretics. And most importantly, once you have resuscitated and stabilized the patient, concurrently one has to look into the etiology, whether it's an underlying coronary syndrome or underlying arrhythmias or underlying high blood pressure or underlying valvular lesion, and necessary measures taken to optimize these underlying conditions. So now we'll switch gears. So that's about the monitoring predominantly of the ultrasound, echo, and other tools that we have, pro-BNP, carbon dioxide gap, mixed venous oxygen saturation. So when it comes to management, obviously once you stabilize, we need to correct the underlying cause. We are here to look into the evidence. In cardiogenic shock, would you do coronary artery revascularization if there is an underlying acute coronary syndrome? So we have to look into evidence. If you look into the shock trial that came very early on, which really looked into whether in cardiogenic shock you would do early percutaneous intervention or late intervention. It shown the early intervention in cardiogenic shock was shown to reduce the 6 months mortality, and that was statistically significant. Then there was a cohort study, which was a large cohort study published in 2050 of 60,833 patients, where early revascularization was done in patients with cardiogenic shock, and it showed significant reduction in mortality in all subgroups of patients, including elderly patients. And in this cohort study, it was shown that the fibrinolysis is not necessarily very effective in patients with cardiogenic, and one should go for early vascular intervention to recanalize the vessels is the way to go. So when you look into the European Society of Cardiology or other recommendations for multivascular disease in acute coronary syndrome in cardiogenic shock, the recommendation is staged PCI, percutaneous intervention, has to be done even for a non-infarct related. So for the infarct related artery, you have to do immediate intervention. For multi-vessel disease, where there are other vessels involved, staged PCI has to be done, which gets a moderate recommendation with a good level of evidence. Then the most recent study is the culprit shock trial. So in this, why we only target the culprit vessel? As the name sounds, is the culprit shock. So here they had two groups where in one, they only opened up the vessel, which was the cause for the cardiogenic shock, as opposed to the multi-vessel percutaneous intervention, where they sort of intervened and recanalized all the vessels. So they looked at the composite endpoint, which is the 30-day mortality with acute kidney injury needing RRT. If you see the group where only a culprit vessel was opened and the other vessels were left alone with a later intervention in a staged way, had a better outcome. And 30-day mortality also was significantly less, where only a culprit vessel was opened as opposed to all the other vessels being opened. And in patients where the vessels are non-revascularizable, there is a signal towards emergency cardiac surgery in this. So ideally, you would want to open up in a percutaneous sort of an intervention. And the culprit shock trial really showed patient comes with cardiogenic shock, identify the culprit vessel, open it up, that will improve the outcome as opposed to trying to open all the vessels. That's what the indication is. So there was this IABP shock 2 trial where they said that 70% of the cardiogenic shock following acute MI that comes have multivascular. So if you have a patient coming with cardiogenic shock, invariably it is due to multivascular disease in 70%, in which 4% went for acute CABG, where they took up for surgery in an acute situation. And they found when they compared the outcomes between the percutaneous intervention versus CABG, mortality was found to be similar in these two. So, which is also very encouraging that they could be subjected for early CABG if percutaneous intervention is not possible. So, that's the evidence we have, friends, about a patient comes with cardiogenic shock. One needs to contemplate percutaneous intervention and go for the culprit vessel to improve outcome. If unable to open up the vessels through angiographically, because 70% have multivascular, CABG also could be considered, is what the evidence is. Now, the big question for all our intensivists is the evidence for inotropes and vasopressors. So, what is the right inotrope or vasopressors to be used? So, this is very important for intensivists because I see some of the cardiologists still using dopamine, which I would say is a malpractice. The reason is there are studies like SOAP2 trial, which has compared norepinephrine versus dopamine. And it has shown that in patients with cardiogenic shock, dopamine increases. So a cardiologist uses dopamine in cardiogenic shock, it means he's doing a malpractice because it increases mortality. And this is the study which has shown it versus the tachyarrhythmias. And there are evidence that has come from cardiology groups telling us that don't use dopamine. Then there is this Optima trial. And before I remember in our own sort of a group, cardiologists were using more of epinephrine. So this was an Optima trial, which has compared between norepinephrine and epinephrine. And they found that hemodynamic efficacy of epinephrine was similar to norepinephrine with its ability to maintain MAP and cardiac index, but epinephrine caused worsening tachyarrhythmias, causes tachycardia, worsening lactic acidosis, and most importantly, the epinephrine group had increased incidence of refractory shock. So all the more reasons that the first choice of drug in cardiogenic shock has to be norepinephrine, and all intensivists follow this to the T, and it is for cardiologists to learn that dopamine is bad, epinephrine is bad for cardiogenic shock. And this was the study where 57 patients, they had 30 norepinephrine group and 27 in epinephrine. And if you show refractory shock was 7% in norepinephrine and 37% in epinephrine. So cardiologist has no business to give dopamine in cardiogenic shock, has no business to give epinephrine in cardiogenic shock. It's always norepinephrine. Because I see cardiologists still using dopamine, which I would call it as a malpractice. And there is meta-analysis, friends, from the French group, 2,583 patients with cardiogenic shock. And they found in these 2,583 patients with cardiogenic shock, 37% of them had got epinephrine. And this group, there was threefold increase in the risk of death, and that was statistically significant. So if cardiologist is using epinephrine for cardiogenic shock, he's increasing the risk of death by threefold, was shown from this sort of a meta-analysis. So there's no business to start dopamine or epinephrine in patients with cardiogenic shock. If someone is starting that, please correct that cardiologist. And what about post-cardiac arrest, post-resuscitation shock? It is shown epinephrine increases hospital mortality. And if you look at the all-cause mortality, odds was 2.6 with a significant confidence interval P of 0.002. And even the cardiovascular death adjusted odds ratio of 5.5 and a statistically significant increase in mortality when used epinephrine. So please, for God's sake, don't use dopamine in cardiogenic shock. Please don't use epinephrine in cardiogenic shock. Both increases mortality, and I still see cardiologists using it. I have no hesitation in telling cardiologists use it, and I'm sure people listening to this know who all are the people who tend to keep using this. So many of them are not updated, unfortunately. And dobutamine. So dobutamine, and this is another strange feature. I see many cardiologists oppose dobutamine. God only knows. And evidence has clearly shown the benefit of dobutamine. Level 2B recommendations, the DOREMI trial. So the DOREMI trial has looked into comparison between dobutamine and milrinone, and they found it is non-inferior. So this was a study that came from Canadian group, 192 patients, 96 patients in the dobutamine group, 96 in the milrinone group. They looked at the composite primary endpoint, which is hospital mortality, post-cardiac arrest, sort of a cardiac arrest, acute coronary syndrome, stroke, renal replacement therapy. So these are the sort of a composite primary endpoint they looked into. And they found that a composite primary endpoint was no different as compared to milrinone. And there was this observational study where in 30 patients where dobutamine was used, in fact, they showed reduced arrhythmias. I've seen cardiologists hesitant in using dobutamine, citing that they'll have arrhythmias. And this particular study showed there was reduction in arrhythmias, there was reduction in oxygen consumption, and dobutamine group had lesser rise in the lactate. So it prevented the rise in the lactate. So we had to adopt and embrace dobutamine more is what the evidence says. And how about levosimendan? I think our cardiologists were enthusiastic about using levosimendan. So the SURVIVE trial, which came in JAMA from the French group, was the last study in 1,227 patients with cardiogenic shock, compared levosimendan and dobutamine. They looked at 180-day all-cause mortality. There's no difference between levosimendan and dobutamine group. Levosimendan group had higher occurrence of atrial fibrillation, hypokalemia, and headache. And what about the Cochrane? So the Cochrane database review looked into levosimendan and showed levosimendan really did not have effect on reducing the short-term mortality, where you see the confidence interval was not significant. Levosimendan had no ability to reduce the long-term mortality. So dobutamine seems to be good enough at this point of time, does not seem to have any inferiority when compared to milrinone, or is non-inferior to levosimendan, because levosimendan also did not show any survival benefit. So when you look into overall sort of a recommendations from cardiological society only, friends, so the vasopressor, first vasopressor of choice is norepinephrine, and dobutamine should be the first line inotrope. Milrinone is second line inotrope, and levosimendan also is a second line inotrope, more so beneficial in someone who has already been on beta blockers. So this is all the evidence we have with regards to the usage of vaso. So don't use dopamine, don't use epinephrine, use noradrenaline, and adopt dobutamine. Dobutamine is recommended, and it has a very favorable benefit, reduces the risk of arrhythmias. Although cardiologists have argued with me that it increases arrhythmias, reduces oxygen consumption, and improves the lactate. So it has all the beneficial effects. So coming to the last bit about the sort of a buzz that people are all getting excited with is the use of mechanical circulatory support. And what is the evidence? We have various mechanical support. We have ECMO, we have balloon pump, we have impeller. So where is the evidence heading? So when you talk about mechanical circulatory support, so one has to bear in mind mechanical circulatory support is a bridge to either cardiac transplantation, or it's a bridge to a definitive decision of correcting the underlying cause. And the recommendation is class 2B, moderate recommendation with a decent level of evidence as per American Heart Association 2020. But sustained survival benefits from the mechanical circulatory support at this point of time appears limited. So when you look into the evidence, so there was this IABP Shock 2 trial that came from the German group, which compared balloon pump versus impeller. So it compared these two, and they showed the mortality was no different between balloon, and impeller is very expensive in India. It costs around 20 lakhs. So there was no mortality sort of a benefit with impeller compared to balloon pump. So when you look into the usage of mechanical circulatory support, when you look at the US database, 20% of acute MI cardiogenic shock were put on assisted mechanical circulatory support. And in their database, the most commonly used mechanical circulatory support was impeller in 66%. VA ECMO was used in 22. So French people have somehow taken liking for VA ECMO. Most of the French database cardiogenic shock shows the usage of VA ECMO. US database shows more usage of Impella. And combination was used in 10.5% in this US database. And this database showed there was improved survival with usage of these mechanically circulated devices. But is this translated in randomized controlled trials? The answer is a big no. So there are 2-3 trials. So this was a nice trial that came from the ZEG group, the Costa Rican group in 2023, ECMO cardiogenic shock trial, which was done in 117 patients, where 58 patients who had sort of a cardiac arrest were put immediately on mechanical circulatory support of ECMO. And there were 59 who were not immediately put on mechanical support. They looked at primary composite endpoint, which was death, cardiac arrest, and needing additional mechanical circulatory support. As you see, there was no difference in someone who was immediately put on ECMO versus the group which was not immediately put on ECMO. And when they looked at all-cause mortality, there was no significant difference between the ones who were put on immediate ECMO as to not immediate ECMO group. And the crossover in the not so immediate ECMO group later on needing ECMO was around 39% in this particular trial. Basically, this trial said immediately rushing and putting someone on ECMO really did not make a difference is what was shown. Then there was this another new trial called ECLS shock trial, again came from the German group. Quite a big study, 417 patients randomized between extracorporeal or mechanical circulatory support group and control group. They looked at the mortality. There was no difference between the mechanically circulatory support group and the control group. As you see, the P was not significant. But what they found is the ECMO group or mechanical circulatory support group, especially who are on ECMO, had increased risk of bleeding. And these patients who were put on ECMO, most of them showed increased LV afterload. And this is a study that came from Japan, which showed if someone is put on VA ECMO as a mechanical circulatory support for cardiogenic shock, it has to be combined with intra-aortic balloon pump or impeller. And this combination has shown to increase the survival by offloading LV, because most of these patients who are put on VA ECMO following cardiogenic shock tend to go into LV afterload increase. And offloading has to be done by LV venting, either with balloon pump or impeller, was shown from this particular study. And even there is a meta-analysis combining all these 4 trials of ECMO, where 4 RCTs were combined. And they tried to compare between early VA ECMO for cardiogenic shock versus optimal medical therapy. And they looked at the 30-day death rate, and they found no difference or no reduction with VA ECMO's ability to reduce the death, even when they combined all 4 RCTs. As you see, odds ratio was 0.93 and confidence interval did not attain statistical significance. So this is the data we have. Although we are all overzealous with the use of ECMO, but if we really dig into the data, there's no compelling sort of a signal saying this ECMO really saves a lot of lives, at least from the evidence point of view. I know most of us are doing this, but from evidence point of view, there's no compelling evidence to say that it has improved the outcomes. So that's about the evidence. So there are evidence for NIV. I think that all are done and dusted. So I've only picked up coronary intervention evidence, vasopressor inotropes, and mechanical circulatory support. So we'll just wrap up this talk with algorithmic management of shock. So when you have a cardiogenic shock, I think any trainee has to look into 3 broad dimensions. So managing the etiology, optimizing hemodynamics, and managing other organ dysfunction. So etiology, I said you have to look into 4 etiologies. Coronary syndrome is the commonest one, followed by arrhythmias, hypertension, valvular, and sometimes you have cardiomyopathies. Optimizing hemodynamics, your whole optimizing hemodynamics is based on improving the organ perfusion and improving the myocardial contractility. How do you improve organ functions? By optimizing preload, optimizing blood pressure, and treating the underlying cause. How do we optimize preload? If they are fluid overload, you give diuretics, and sometimes you may resort to extracorporeal removal of fluid by scuff and so on and so forth. And if there is hypotension, you have to optimize with vasopressors. The first line is always norepinephrine combined with dobutamine. And the second line would be your other milrinone or levosimendan. And treatment of underlying cause, if it is sepsis leading to it, arrhythmia leading to it, you have to treat the underlying cause. Managing others, how do you optimize lung functions? Put them on NIV. So the studies are very compelling to tell us NIV improves the outcome by reducing the work of breathing, reducing the afterload, and recruiting the alveoli, and improving the oxygenation and reducing the shunt fraction, and dialysis if needs be for acute kidney injury that sets in that phenotype, because if the second phenotype, acute kidney injury, sets in early, so you may have to consider dialysis to optimize the kidney function. And you need optimal sedation. All this goes hand in hand to optimize these patients. So when you talk about cardiogenic shock, as I said, you need to really delineate whether it's LV involvement or RV involvement. So if there is predominantly RV dysfunction, you have to optimize the RV function with optimizing preload, because as you know, RV is very much dependent on the preload. And you have to take measures to reduce the RV afterload by improving the LV function, reducing pulmonary vascular resistance by using endothelin receptor and using pulmonary vasodilators like endothelin receptor antagonists or phosphodiesterase inhibitors, and reducing the intrathoracic. How do we reduce intrathoracic pressure? By optimizing PEEP. So, and LV filling, how do you optimize LV? By obviously optimizing the LV filling. If the hypovolemic, you have to give gentle allocots, or by reducing the LV afterload by using dobutamine and avoiding tachyarrhythmias and avoiding tachycardia by using beta blockers as deemed appropriate. And balloon pump is another modality to reduce afterload. So this is just a pictorial representation. If it's predominant RV, you have to use these measures. If it's predominant LV, so these are the measures you need to undertake. Sometimes you have decompensated heart failure with accelerated hypertension with acute MR/IR. So you have to reduce the afterload, sometimes by using sodium nitroprusside. And if there is increased lung congestion, you have to reduce the preload by using NTG. And if there's a known systolic heart failure, use dobutamine or balloon pump. If there's a known diastolic heart failure, try to use more beta blockers plus vasopressors. If there's a diastolic heart failure, one should take caution to avoid usage of inotropes or sodium nitroprusside, which can worsen the diastolic heart failure. So just another picture to show you, in acute decompensated heart failure, there are 4 important pillars using mineralocorticoid receptor antagonists, beta blockers, SGLT2 inhibitors, and angiotensin receptor neprilysin inhibitors. Along with this, if there is tachyarrhythmia, use anticoagulants, digoxin, or cardiac resynchronization therapy. Tachycardia, lessen it with beta blockers or ribavirin. And if there is pulmonary edema, use loop diuretics, thiazides. If advanced heart failure, use pulmonary vasodilators like Versigort, omecamtiv, or mechanical support devices, and they have to be listed for heart transplant. And if there is valvular lesions, consider surgical options, and NTG if there is a preload issues, or hydrolysine for arterial dilators. If ARNI is found to be prohibitive with regards to cost, you can use AC inhibitors or ARB. And if many of these heart failure patients, you have to do iron studies. If there is iron deficient, you have to give ferric carboxymaltase to supplement and optimize the iron. So this is pictorial sort of a dimensions of management in patients with complicated heart failure. So you can remember mnemonic, I call it as AQBCD. A is use aspirin, aldactone is mineraloreceptor, AC inhibitors, B is beta blockers, C is flexane or anticoagulation, D is diuretics, N is nitrates, S is statins or SGLT2 inhibitors. Just the last slide, there are other components in addition to managing all the cardiac specific interventions to optimize heart failure. There are other sort of bundles that you need to adopt to improve outcomes. So obviously you have to take measures, infection control measures. You have to put in place WAB bundles, CORTI bundles to prevent hospital-acquired infections. And if there is acute coronary syndrome, put in measures for good analgesia and avoid pain in these patients, and early usage of NIV, and weaning from the ventilation by spontaneous breathing techniques, and early mobilization of these patients with good physiotherapy and occupational therapy goes a long way to improving cardiac outcomes. Stress ulcer prophylaxis, good choice of sedation and analgesia with more of opioid sort of a opioid usage to reduce the sympathetic surge in these patients goes a long way in improving the outcome. And early adoption of focus to optimize your volume status and cardiac status is very important. And multidisciplinary team approach. So these are all the other quality sort of a dimensions that one could adopt to improve the outcomes in these patients with cardiogenic shock. So that's about it, friends. So I tried my best to cover most of the dimensions of these patients with cardiogenic shock. So request you all to submit your valuable work to Journal of Acute Care. Of course, you can visit my website to read it. Thank you, Bernardo.